Grand Rounds. Welcome to all the school refugees who are here for Bioethics Grand Rounds. I'm Naomi Laventhal. I'm one of the faculty in the Center for Bioethics and Social Sciences and Medicine. I'm also a newborn intensive care doc. It's my pleasure to introduce Dr. Doug Opel, who is an associate professor in the Division of General Pediatrics and Hospital Medicine at Seattle Children's Hospital. He's also the section head for bioethics in the Division of Bioethics and Palliative Care. He's the vice chair of the ethics committee at Seattle Children's and the associate director of the Truman Katz Center for Pediatric Bioethics, all at the University of Washington School of Medicine. I feel like Dr. Opel's originally from one of ours. He's from Rochester, Minnesota. He got his bachelor's degree at Duke University in biology and philosophy, which makes him really perfect to be here giving a talk at Bioethics Grand Rounds. He got his MD from University of Chicago, Pritzker School of Medicine, and his MPH in health services and health policy and research at University of Washington School of Public Health. And did his residency and chief residency at University of Washington, and also was a fellow at the Truman Katz Center for Pediatric Bioethics. It's like exhausting to introduce him. He teaches at the medical school and at the law school at University of Washington, holds a number of editorial positions. I've had the pleasure of getting to know him on the AAP Committee on Bioethics and organizing bioethics topics at the Pediatric Academic Societies. He holds a number of grants, all mostly in the area of vaccine hesitancy. Is a former Greenwall scholar and has, by my count, 69 peer-reviewed publications. I want to give you the rest of the time to enjoy his great talk, so please welcome me in. Please join me in welcoming Dr. Opel.
Thank you, Naomi. That was a kind introduction. Can everybody hear me okay? Yeah, okay. I'm going to probably try to untether myself from the podium, but I don't have a clicker, so I'll return to the podium to advance slides as I move through them. I've been here since Monday, and it's really been a great visit. And I've a native, as Naomi sort of suggested, I'm a native Midwesterner. I'm originally from Wisconsin, so it's really great to be back here, and I've really enjoyed my visit. This topic I want to talk with you all about today, shared decision making, has been a topic of increasing interest to me over the last several years. In part, that interest has been practical. I, as a general pediatrician, have been interested in how I should be practicing and implementing shared decision-making in pediatrics. It's also been theoretical and conceptual. Been interested in arguments for when and how we should be using shared decision-making. So I'm going to try to combine those two interests, practical and theoretical, in this talk today, and really pitch a proposal to you all on how I think we should be practicing shared decision-making in pediatrics. Now, can I get a show of hands? How many of you are actually pediatric clinicians? So many of you. Okay, for those who aren't, I think you'll still find this talk interesting, relevant, compelling, or at least I hope, because even though I base a lot of what I talk about in specific clinical pediatric scenarios, I do also talk more broadly about concepts relevant to shared decision-making and medical decision-making that aren't exclusive to pediatrics. I have nothing to disclose. And this is the outline I want to follow over the next 15 minutes or so. I'll begin with talking about the complexities of practicing shared decision-making in pediatrics. Spend most of my time talking through a framework I published a few years ago for implementing shared decision-making in pediatrics. And then I'll end with sort of operationalizing how that framework might be used in specific clinical scenarios from pediatrics and talk about next steps. The first, complexities of practicing shared decision-making. So I had an opportunity maybe 3 or 4 years ago to comment on the state of shared decision-making in pediatrics. And as I reflected on what I would write for that commentary in the pages of pediatrics, I reflected on how I myself was practicing shared decision-making. And as a general pediatrician, I mostly practice in the outpatient setting, but I do still do some inpatient pediatrics too, primarily in the newborn nursery. And I was there that I was actually attending when I was thinking about how I use shared decision-making. And as I reflected, I realized that every day as I was in the newborn nursery, I was recommending several interventions or therapies every day to parents for their newborns. These were interventions like newborn screening, breastfeeding, intramuscular vitamin K to prevent hemorrhagic disease of the newborn, hepatitis B vaccine, supine sleep position, erythromycin iomin to prevent neonatal conjunctivitis. And as I reflected on these interventions that I was talking about with parents, I realized, these decisions or interventions have a lot of similar features. They all are decisions of substantial benefit. They all have minimal risk. They all are really universally recommended for parents of newborn infants, with very few exceptions. But despite those commonalities, the degree to which I was sharing the decision to do these interventions with parents was very different. For some of these interventions, I was very much invoking what I thought was shared decision-making, inviting the parent to tell me what they preferred, have a chance myself to contribute to that conversation about benefits and burdens of the available options, and reach a mutual decision. For other interventions on this list, I was doing the opposite. So take the example of breastfeeding. I almost always, as I reflected, entered into this decision with parents with an open-ended question: do you plan to breastfeed? As a way to have parents, mom, communicate to me their preferences and why they had those preferences, and for me to talk about the benefits of breastfeeding and also potentially the benefits of formula feeding, if that was important to talk about, and we would reach a mutual decision. For other decisions, like newborn screening, I approached it quite differently. I didn't use any open-ended question, nor did I have any intent to really share in this decision with parents. I would say, you'll get a heel poke before you leave as part of the newborn screen. I would answer questions if they had them and expand on information regarding the newborn screen, but it wasn't really my intent to share in this decision to reach a mutual agreement. And as I reflected on this, I thought, well, why is this? Why am I doing such different decision-making approaches for these interventions that share so many common features? Well, undoubtedly, the reason was that there are real differences between these interventions, and that drove potentially how I was approaching how much I shared in these decisions with parents. And I think that was appropriate. As we take these two examples, breastfeeding and newborn screening, they have decisional features inherent to them that really are almost polar opposite. Breastfeeding could be described as therapeutic, non-invasive, parent-implemented, longitudinal. Newborn screen, on the other hand, preventive, invasive, clinician-implemented, and a discrete event. So almost certainly this was contributing to my different approaches to these interventions, but it was the more interesting question to me is, how should they be? How should these decisional features shape my use of shared decision-making, and more, whether or not I use shared decision-making and why? So as I also reflected more about how much I was sharing in these decisions with parents, I also had to admit to myself that probably some of this variability was due to confusion on my own part on how to actually practice shared decision-making in pediatrics. As many of you know, the original conception of shared decision-making was done in the context of an adult competent patient. Kathy Charles was one of the first to sort of describe this process in the context of an adult competent patient, where both parties, she said, share information, take steps to build consensus about a preferred treatment, reach an agreement on the treatment to implement, which involves several things, including exploring and incorporating patient values, preferences, and beliefs to ensure patient decisions match their preferences. So even if we consider this all straightforward, and we've honestly been spending 30 years trying to unpack what this all means, even in the context of a competent adult patient, it remains an open question. This: how do we practice shared decision-making when the intended beneficiary of shared decision-making in pediatrics primarily is a child patient who does not have the capacity to fully share in the decisions that affect his or her interests? I was realizing I was struggling with how to implement shared decision-making because my patients weren't adult competent patients. They were children who lacked decision-making capacity in large part. So as I tried to think about how I might get past some of, or answer even that question, I thought, well, look, why not just make the parent the intended beneficiary of shared decision-making? And for a lot of reasons that makes sense. In our society, we permit parents to raise their children as they choose. In healthcare, we permit them to make decisions on behalf of their child. And so it makes sense to share information with them, explore the parent's values, preferences, and reach a mutual decision about what to do for the child with the parent. But even so, even if we make parents the beneficiary of shared decision-making, there are inherent complexities to that aren't present with a competent adult patient. For instance, Here's one of them. There are inherent constraints on parental decision-making as surrogates acting on the behalf of the child. So we in pediatrics very much help or try to ensure that a parent's decision-making as a surrogate is aligned with the child's best interest. And so if we're going to do these core elements of shared decision-making, like eliciting parent preferences, this usually happens in pediatrics in conjunction with a scrutiny of whether those preferences actually serve the child's best interest. And that, of course, at least can seem to undermine how shared a decision is. And also, of course, children grow up and become adolescents with emerging autonomy. And out of respect for them as persons, would require them to be included in the decision-making process. And so it occurred to me that unlike in the adult context, where primarily shared decision-making serves a singular role to promote patient autonomy, in pediatrics it seems to have to serve or accommodate multiple goals: protecting a child's interests, incorporating parental values, honoring the emerging autonomy of adolescents. So after I wrote that commentary, I began to think more about how to navigate these complexities and went to the literature and talked to colleagues on how they do that, how they are getting past these complexities, and largely realized that everyone was struggling with this. These are some commentaries around the time that I found that reflect confusion and similar questions of how do we actually use shared decision-making in pediatrics, when should we use it, and how. And so I really appreciated that there was a gap here in shared decision-making that required some attention and perhaps a framework for how to standardize the use of shared decision-making in pediatrics, when to use it and how. So I set out to do that, and let me now transition to explaining that framework that I developed for implementing shared decision-making in pediatrics. And so I used a sort of simple three-step process to develop this framework. I began by integrating prior conceptual work on the doctor-patient relationship and shared decision-making. I then adapted existing models for shared decision-making designed for use with adults, adapted them to the pediatric context. These are models like Glenn Elwin's three-talk approach, Alex Kahn's shared decision-making continuum, Simon Whitney's typology for medical decision-making. And then I subjected early versions of my framework to iterative critiques by experts in relevant disciplines, ethics, pediatrics, medical decision-making. And oftentimes started over, seriously revised my framework, and began again with this iterative process. And even with this, I would consider my framework that I'm about to show you really still provisional, sort of as a foundation that we can build upon, continue to adapt and add to over time as we try to make sure this process really reflects and captures shared decision-making. And I'll speak to some of those elements that I think still need to be added and some validation steps that need to occur to ensure we are capturing shared decision-making in pediatrics. So this is the provisional framework, and I'm going to speak to it broadly here and then spend subsequent slides to go more into detail on the specific aspects of this framework. So first thing I want to say is my intent here was to develop a framework for use by clinicians, to give them practical guidance for when and how to use shared decision-making. Any discrete decision could be fed into this framework at step one. And then, as you see here, the framework consists of 4 steps. The first 3 steps really prompt the clinician to answer a question, the answer of which helps them move through the framework, ultimately reaching step 4, which gives them guidance on the type of shared decision-making to use. Now, one thing I should also say is my intent here as a starting place was to capture shared decision-making with parents of young children, not adolescents. So this is an element that I think needs to be added, or at least be considered in future work for this framework. My intent was really to capture shared decision-making of parents of young children, where it's less relevant to include them in the decision-making process. So let me now move to walking through each of these steps. And I'm going to spend the most time with this first step, the medical reasonableness step. This step prompts the clinician to ask, does the decision include more than one medically reasonable option? You can see here the outcome of this step is whether or not the clinician uses shared decision-making at all. So I think this is a critical step to get right. Because I feel like in my experience in talking to clinicians, pediatric clinicians, this is one that we often get wrong. We use shared decision-making when we perhaps shouldn't, and don't use shared decision-making when we should, because of lack of clarity of whether there is more than one medically reasonable option. So the rationale for this step was provided by Kathy Charles in the late 90s and reiterated by Simon Whitney in the early 2000s when he said shared decision-making in its fullest sense occurs only when real choice exists and the physician involves the patient in the decision. And I would agree with this in principle, that seems like real choice needs to be present. An important prerequisite for shared decision-making. It's hard to imagine how to share in a decision when there's no decision to share. But of course, the devil's in the details here. The operative words here are real choice. We're going to hinge whether or not we use shared decision-making on whether real choice exists. We ought to be really clear with ourselves when real choice exists and what that means. So how do we define real choice? Well, others have weighed in on this issue before me, saying real choice is when there's equipoise, in which options are really options, or where there are reasonable alternatives, or where there are two or more medically reasonable choices. And these are all good starts, but I think lack the content clinicians need to sort of guide whether or not they use shared decision-making. And so I entered the fray with this framework and offered this definition. Real choice is when there's more than one medically reasonable option, with medically reasonable defined as at or above the standard of care. So really I'm anchoring or linking what is medically reasonable to the standard of care. So I better define that for you, since there are many definitions out there for standard of care. I am defining standard of care consistent with the legal definition as minimally competent care that other physicians would provide under the same circumstances. So I see an option that represents minimally competent care as an option that there's evidence of net benefit, and an option that's promulgated by professional clinical practice guidelines. I don't see an option as minimally competent as an option that has evidence of net harm or is medically contraindicated. Now, my rationale for anchoring what is medically reasonable to the standard of care is to help ensure a consensus basic minimum, a true floor where I think hopefully we can all agree below which wouldn't be a medically reasonable option. And indeed, clinicians who do not practice the standard of care risk medical malpractice, negligence, and or professional discipline. So it seems at least appropriate that what is medically reasonable at least conform to the standard of care. Now, it might be helpful here to define a related term to the standard of care, what I call standard practice. Now, these terms may be synonymous to you as you start to think about how do I define standard practice and how might that be different from standard of care. And that's okay. They are very interchangeable terms, and as I was beginning to think about it, I myself thought they were interchangeable, but I would like to posit that there are times when they diverge, and there are implications when they diverge for whether real choice exists. So I've defined, as I mentioned, standard of care as minimally competent care. There are many definitions out there for what is standard practice. I like this one from my Academy of Pediatrics. They generally all say similar things, but this one is standard practice is legitimized or validated based on scientific or epidemiologic data and representing the widely agreed upon state-of-the-art, high-quality level of practice. Now, the reason why these two terms are often synonymous or interchangeable for us is because there's a lot of clinical scenarios where what is minimally competent care is the widely agreed upon state-of-the-art, high-quality level of practice. These are indeed aligned. But again, I'd like to posit that there are scenarios where these diverge. Standard practice, the options that standard practice exist at a higher threshold than what we would consider to be the standard of care, minimally competent care. And the reason for that is because there are clinical situations where there are many options where there's evidence of net benefit to the patient, and the option we're choosing to be standard practice may be the one where there's the highest net benefit to the patient. But that doesn't mean that there aren't others below that where there's maybe lower net benefit, but still enough net benefit to the patient that would fall above what we would consider to be minimally competent care or the standard of care. Let me give you some graphic examples to sort of illustrate how sometimes the standard of care and standard practice will align and sometimes where it would diverge. This is one example where I think it aligns at its most basic regarding immunizations, something that I talk about a lot and practice in my clinical practice a lot. What are the immunization options for a healthy 2-month-old. Well, here's where standard of care and standard practice align around the recommended childhood immunization schedule, given the substantial evidence of its enormous benefit to children and minimal risk. This is where what is widely agreed upon as the state-of-the-art, high-quality level of practice is minimally competent care, and alternative child immunization schedules will fall below the standard of care, given their evidence of harm. They promote delay of timely immunizations among children. Here's an example of further justifying that alternative immunization schedules fall below the standard of care, is that those who promote them, those clinicians who promote them, are actually disciplined. There's an article or a headline from a recent article regarding Dr. Bob Sears, where the California Medical Board has sanctioned him for promoting alternative medical or immunization schedules. Now, here's an example where I think standard of care and standard practice diverge. Ear infections. Take treatment options for an otherwise healthy 5-year-old who comes in with uncomplicated ear infection, mild symptoms, and a penicillin allergy. Standard practice, I would argue here, is to do nothing, watch and wait, given the child's age, uncomplicated scenario, mild symptoms. Most of these resolve and avoids the risk of antibiotic administration. But that doesn't mean there aren't other medically reasonable options, namely treating with ceftonir or treating with azithromycin given the child's penicillin allergy, because of evidence of some net benefit to those patients. Increased resolution of their, albeit mild, symptoms with treatment. All added some side effects to that given the antibiotics, but overall evidence of net benefit. Lower net benefit than, I would say, watch and wait, but above standard of care, minimally competent care. What would fall below the standard of care threshold, I would argue, would be treatment with amoxicillin, given the child's penicillin allergy would be medically contraindicated. So this is all for us to help be more clear about when real choice does and does not exist. In the immunization example, I'd argue it doesn't. In the ear infection example, it does. When there is no real choice, I agree with others that we ought not use shared decision-making. Instead, we should assume decisional authority and make explicit or even implicit to the parent the one medically reasonable option. This is what we're doing. Now, the parent may not accept this one medically reasonable option, as they have the tendency to do from time to time, but I would argue that this is a separate matter. Whether or not a parent's refusal is acceptable requires a separate consideration and will vary by the refusal. So let me operationalize this step now with all that we've talked about, with 3 examples. Again, I'm going to use a lot of clinical scenarios here, and as a general pediatrician, they're mostly general pediatric. But for those of you operating in other clinical pediatric settings, try to imagine how this might play out in the setting in which you practice. So take a child who has a history of asthma coming to me with a moderate to severe asthma flare. Having trouble breathing, may even have low oxygen as a result. At its most basic, one of the clinical decisions I have to decide about is whether to administer a short-acting bronchodilator to relieve the bronchoconstriction that's part of asthma. Do I administer it or do I not? Does this decision include more than one medically reasonable option? Using this medical reasonableness scale, as I've been talking about, this would be an example where, again, standard of care aligns with what is standard practice, given the substantial evidence for administering a bronchodilator in asthma and negligible risk. This is where minimally competent care and standard practice align. Not omitting it would not be considered to be minimally competent care, evidence of harm by delaying relief of symptoms and prolonging the child's hypoxia. So I'd answer this question, no. This isn't a decision with more than one medically reasonable option. Now, within this decision, there may be. So whether or not to administer the bronchodilator, I would say not more than one medically reasonable option. But within this decision, what type of bronchodilator do I administer? Albuterol or levoalbuterol? Yes, maybe there's shared decision-making indicated there. Or how I administer it, nebulizer or puffer. Again, those are different. I'm really talking in its most basic, do I administer this or not? And I would say, no, I would not use shared decision-making. And as I mentioned, parent could decide not to accept this one medically reasonable option. But again, that would prompt a separate consideration of assessments of risks or harms to the child. And I would have to decide, do I respect the parent's refusal? And I personally use the harm threshold here. Does the parent's refusal put the child at significant risk of serious harm. In this case, given the child's extremis, the parent does not agree, I would argue I wouldn't respect this parent's refusal, given I have an effective intervention and the child's at imminent risk of serious harm, and I would invoke state intervention. Let's take another example, newborn screening, one I've talked about in the introduction. At its most basic, do I obtain this blood sample or not? Does this include more than one medically reasonable option? And again, here is where I would say the standard of care, what is minimally competent care, is standard practice, and that's around obtaining the newborn screen. Every state has a law, in fact, that requires obtaining a blood sample for newborn screening, given its substantial, not only individual, but public health benefits and negligible risks. Omitting the newborn screen would fall below minimally competent care and not be medically reasonable. Again, I would answer this question, no. And I wouldn't use shared decision-making. And so actually, as I reflected on how I entered into this decision with parents saying, you'll get a heel stick before you guys leave, is an example of that. Not invoking shared decision-making, but more clinician-directed decision-making. Now, parents, again, can say, I don't want to do that. And again, that would prompt me to assess whether this refusal reaches this threshold of significant risk of serious harm. And in this case, I don't think it does, and I would respect the parent's refusal. And in fact, most states, with their newborn screening laws, allow parents to opt out for this reason. How about breastfeeding? My last example. Does the decision to breastfeed or its primary alternative, formula feed, a newborn, include more than one medically reasonable option? Here is where I would argue the standard of care and standard practice diverge, and both are medically reasonable. It's clearly standard practice to promote breastfeeding. My academy considers this standard practice, WHO does, et cetera, given the enormous medical benefits to both the infant and the mother and negligible risks of breastfeeding. But that doesn't mean it is the only medically reasonable option. I would argue that formula feeding has a lot of evidence for net benefit to the child as well. And therefore, hard to argue that it falls below the minimally competent care or standard of care threshold. So I would argue the answer to this question is yes. And we would proceed to step 2 and use shared decision-making. So before we go to step 2, I want to just sort of make transparent some issues with step 1 that I've been myself struggling with. And the first is the fact that, we may get used to practicing at a certain level, standard practice level, and consider the option that we consider standard practice at our organization to eventually be the only option, only medically reasonable option. And we fail to see that there are other options of net benefit to the patient. And therefore, we may not think we should be using shared decision-making when we indeed should be. And this can, of course, be complicated by confusion among us, I'll admit, about the relationship between standard practice and the standard of care. So that requires some further fleshing out, I believe. There also may be no consensus for what is the standard of care. This happens from time to time in pediatrics, not uncommonly. One example is hypoplastic left heart. I would argue there is no consensus about whether palliative or surgical management of hypoplastic left heart is the standard of care. And when there is no standard of care, what do we do? Well, I would argue here, this is precisely where there is more than one medically reasonable option, and we should be using shared decision-making, not avoiding shared decision-making. And lastly, I think clinician bias and values can influence determination of what is medically reasonable. Even though I try to anchor what is medically reasonable in something a little bit more objective, standard of care, I think we have to be cognizant of the fact that we often try to infuse subjectivity in these determinations, and that still exists, and we have to try to counterbalance doing that. Okay, so that is the step I'll take the most time on. And now let me move to steps 2 through 4 a little bit more quickly so I can end with some examples of how to operationalize this framework in totality. So step 2, assuming we answered step 1 affirmatively, prompts the clinician to ask this question: does one option have a favorable medical benefit burden ratio compared to other options? Now, the rationale for this step, as I mentioned at the outset, is to fulfill clinician obligations in pediatrics to ensure that surrogate decisions promote the child's best interests. And ensuring that surrogate decisions promote the child's best interests We were doing some of that in step 1 if a parent decided not to accept the medical reasonable option. But I think ensuring that parent makes decisions that are aligned with the child's best interests is not just ensuring that parents' decisions sort of aren't abusive or neglectful. This also involves us trying to empower the surrogate to maximize benefits and minimize burdens. And so this step is meant to do that. Now, if the answer to this question is yes, the clinician is guided to do what is called clinician-guided shared decision-making. If not, use parent-guided decision-making. And to briefly explain these two different types of shared decision-making, clinician-guided shared decision-making is where the clinician explains each option, its risks, its benefits, in order to ensure that the parent is fully informed, and then explains that all options are medically reasonable here. But then convey what option that the clinician thinks is best based on a reasoned estimation of the medical benefit burden ratios and is transparent with the parent about how the clinician came to that estimation. If parent-guided shared decision-making is used, it looks very similarly, except in explaining that each option is medically reasonable, the clinician says, there is no consensus which option is better, and again is transparent on how they're coming to that conclusion. So the operative question is here in step 2 is how do we do this? How do we determine whether an option is favorable or not? And I think the best way, of course, is to make a judgment grounded in evidence-based probabilities and magnitudes of what the benefits and burdens of the options are. I mean, it's amazing to me how oftentimes I see us not doing this. But let's check ourselves and make sure that when we are making these favorability assessments, they're really grounded in evidence. Now, oftentimes, there is no evidence. Okay, and the question is, do we not make a favorability assessment in those scenarios? Well, I think there's still room for us as clinicians in step 2 to make a favorability assessment that is based on our experience, organizational experience, or expert opinion. But I think I would caution us from doing this. Certainly be transparent with a parent that we're not basing this on evidence, we're basing this on experience or expert opinion, and I would be cautious for us not to make very strong favorability assessments if we're using experience or expert opinion. Now, of course, the major issue here with step 2 is that what constitutes a favorable medical benefit burden ratio, even if it is based in evidence-based probabilities and magnitudes, is still subjective and prone to clinician bias. It still requires us to prioritize those probabilities and magnitudes, right? And that may be infused with our own biases. We're prioritizing side effect A over side effect B. So it's important for us as we make these favorability assessments to talk through how we're doing this with the parent. It's a core component, I would argue, of step 2 to minimize those biases and give parents an opportunity to reject the way we're making that favorability assessment. Now, another important issue for this step 2 is how influential public health considerations should be when making favorability assessments. Now, I think our primary obligation as clinicians is to the individual patient in front of us. And so this favorability assessment really should primarily be focused on the medical benefits and burdens that accrue to that individual patient. But I also think that we have obligations as clinicians to the communities in which we serve. And so I think there's a role here for also including benefits and burdens that accrue to the community or the society at large. Public health benefits and burdens. But it's not entirely clear yet, to me anyway, how to include public health considerations and whether they ought to be prioritized potentially over assessments regarding individual benefits and burdens. So after step 2, we move to step 3 and are prompted to elicit and explore parent preferences regarding the medical reasonable options. And of course, the rationale for this step is to ensure parental values and preferences align with the chosen option. I mean, Glenn Elwyn, about a decade ago, said this nicely: when options exist, and even when one option appears favorable to the clinician, the best choice depends on how the parent values the risks and benefits of the treatments available. Okay, so it's important for us to be clear with ourselves that this is really a critical step. Now, I would argue that what I mean by this step is not just asking the parents what they want to do. I want to go beyond simply eliciting parent preferences. As Epstein and Peters remind us, respecting and responding to patient preferences, the hallmark of patient-centered care, means not just eliciting, but exploring and questioning preferences and even helping patients construct those preferences. Clinicians should understand that they are part of preference construction processes. Now, the justification for this more expansive role, potentially, of not just eliciting parent preferences, but doing things like constructing those preferences with parents, I would say is twofold. The first is, look, we as humans often live unexamined lives. And our preferences are neither clear or stable to us. And it's through our capacity of change and self-reflections as humans that we kind of ongoing are reevaluating and examining what our preferences are. And even if we are clear at any one point what our values and preferences are, we find ourselves in unanticipated situations that we're not sure how those previously known values and preferences actually match to what situation we're in now. And healthcare gives us a good glimpse into this. We often find parents in situations with their children or patients that they didn't anticipate, and how those values now need to manifest in that situation is unclear to many patients and parents. So this process of constructing and shaping our preferences, I would argue, is relational. It's often not done individualistically, but in context of others. As Susan Sherwin wrote a number of years ago, much of who we are and what we value is rooted in our relationship and affinities with others. This process of constructing and shaping our preferences is done through interaction and dialogue and relationships with folks we trust. And I would argue in the doctor-patient relationship, doctors and clinicians are part of that interaction and dialogue and preference construction. Now, what step 3 is not meant to infer is give permission to clinicians to coerce, manipulate, or be confrontational with parents. I'm not saying that. Just because we can be involved in preference construction processes isn't meant to mean that we're trying to get the parent to do what we want them to do. Nor is it meant to infer that we no longer have an obligation, again, to acknowledge or communicate what we are bringing to the table. We all have biases that we bring to discussions, and we need to have insight ourselves what those are and be transparent about them with parents. What this step is meant to really embody is to empower clinicians to help parents assess the worthiness of certain health-related values and prevent us from simply presuming what patients prefer or parents prefer. All right, ultimately we end up here at step 4, the calibration step. And this is the step, as I mentioned at the outset, where clinicians are provided some guidance on the type of shared decision-making to use. So once we get here, we're using shared decision-making. Just now, what kind of shared decision-making ought we use? Now, you see it's visualized as a continuum here with 4 different foci, a strong parent and clinician-guided shared decision-making, and a weak clinician and parent-guided shared decision-making. I'll go more into detail about what those are in subsequent slides, but briefly, a strong clinician or parent-guided shared decision-making is where parents or clinicians appreciably guide the shared decision-making process. The weak versions is where there's much more equal contribution from both parties. Now, I call this a calibration step, really to build in some flexibility to this framework, to accommodate some decisional characteristics that might be present, that might demand a different type of shared decision-making than what the framework suggests you use. And this is because there's increasing evidence, and this is an emerging sort of field in shared decision-making. There's increasing evidence that there are certain decisional features that really ought to sort of drive a certain type of decision-making. For instance, there's emerging evidence in pediatrics, in particular, that when there's time sensitivity involved in the decision or a clinical seriousness of the decision, a large proportion of parents actually prefer clinician guiding the shared decision-making rather than them guiding the shared decision-making. So when those decisional features and others here that I list, and even others that we're not aware of yet, if they're, as we gain understanding of when those are present, it gives, this calibration step is meant to give the clinician some flexibility to modify slightly from where they land based on their answers to steps 2 and 3 somewhere else on the continuum. So returning to sort of what the strong version of clinician-guided shared decision-making looks like. Now remember, this is the scenario where there is a favored option based on step 2. based on the clinician's reasoned estimate of the medical benefit burden ratios. And after step 3, after trying to elicit and explore the parent preferences, realize the parents really don't have strong parent preferences regarding the available options. This strong version really gives permission for the clinician then to guide the shared decision-making, doing the things there in the box, explaining each option's risk benefits, ensuring parents know all options are medically appropriate, conveying what the clinician sees as best and why, and reviewing with the parent what they prefer, eliciting, exploring, helping instruct based on what the clinician just said, and failing to see or hear from the parents if they have strong preferences, getting that explicit acknowledgement that they don't really prefer, then the clinician just simply seeks explicit parent agreement with the clinician preferred option. And on the other end of the continuum is the strong version of parent-guided shared decision-making. This is applicable when there is no favorable option based on the clinician assessment in step 2, and in step 3, parents do have strong preferences about one of the medically reasonable options. And here, the clinician ought to let the parent guide the shared decision-making and simply be committed to implementing the intervention that is most closely aligned with the parent's preferences. Now, the weak version of clinician-guided shared decision-making largely occurs when there is, in step 2, a favored option, but in step 3, the parents prefer something else. Okay, and I think this, my intention here is to allow for much more interaction, mutual contribution from both the parents and the clinicians about what to do. So the clinician may try to persuade here about why parents should embrace the values and preferences aligned with the clinician-preferred option, but really remains mostly committed to hearing more about the parents' reasons for their preferences and reaching a decision aligned with those preferences. The weak version of the parent-guided shared decision-making really occurs in those circumstances where there's no clinician-favored option based on step 2, and the parents don't have any strong preferences. So there's no predilection really on what intervention to or which option to implement. And so in this circumstance, the clinician may decide to convey additional information, some of their own expertise, experience, maybe some interpretation of the evidence regarding certain options, but is doing that really to return to step 3 and help parents further explore their values and preferences and ultimately reach a decision aligned with those evolving values and preferences. All right, let me in the next 5 or so minutes operationalize this framework in its entirety, again using some clinical scenarios that I might encounter, at least in general pediatrics. So take management options of early uncomplicated appendicitis. A child, let's pretend I'm a pediatric surgeon, coming to me with early uncomplicated appendicitis. How would this framework be used? Well, the first, again, decision that I would hope the pediatric surgeon entertains is, does this decision include more than one medically reasonable option? And I would argue, yes, it does. Surgical management is, of course, a medically reasonable option. We have a lot of evidence of its net benefit here. But there's also evidence now of medical management, antibiotics to treat early uncomplicated appendicitis. So I'd argue that is also a medically reasonable option here, and the surgeon should proceed to step 2. Does one option have a favorable medical benefit burden ratio compared to other options? Here I probably would argue yes. Surgical option is still probably favored. In fact, most pediatric surgery guidelines that I've looked at recently still recommend this as the favored option, given the enormous wealth of data for this option and the only new evidence for the medical option. So we might have the surgeon use clinician-guided shared decision-making in this case and elicit parent preferences regarding these 2 medically reasonable options, even though one is favored. And if they're typical parents, they probably would have high, strong preferences regarding one of these options and probably might have preferences for the least invasive option, at least to start. And in that case, I would argue we would use a weak version of the clinician-guided shared decision-making where there's much more negotiation, but ultimately the provider or the clinician or surgeon would be committed to implementing that intervention that's aligned with the parent's preferences. How about male newborn circumcision? Does this decision to circumcise or not include more than one medically reasonable option? The answer, I would say, is yes. fact, my academy suggests both are medically reasonable options, given there is some evidence of net benefit for circumcision, but there's also risks. So both circumcising or not are considered to be medically beneficial and reasonable. Here's where we might diverge. I sort of answered this question, no, there's not one favorable medical benefit burden ratio, but I could see how one might argue, yes, there is one. Circumcision, there is evidence of net benefit given reduction of UTIs in kids who are circumcised. So you may decide to answer this as yes and use clinician-guided shared decision-making rather than parent-guided shared decision-making. And so I could certainly accommodate that. If we decide to use parent-guided shared decision-making, and if parents are typical parents in this circumstance and have strong preferences to do one of these two options, I would simply advocate for a strong version of parent-guided shared decision-making, letting them guide the shared decision-making process and implement simply the intervention that they prefer. If we went the other route and answered step 2 yes, we would likely end up at a weak version of clinician-guided shared decision-making, which could allow for some negotiation, but ultimately, again, commit to implementing the intervention the parent preferred. Lastly, what about management of sedentary overweight child with hypertension? This is one that's common in general pediatrics these days. Does this decision include more than one medically reasonable option? I would argue, yes, it does. There's nutritional options, improving the child's diet. There's physical activity options. There's limiting screen time. There are a myriad of medically reasonable options, all with net benefit above what we consider to be minimally competent care, the standard of care threshold. Does one option have a favorable medical benefit burden ratio? Well, here I would answer yes. Given the hypertension component, we might advocate for a nutritional intervention if the child eats a lot of salt, for instance, or a physical activity option is favorable because it's linked to reducing blood pressure. So I would argue there could be a scenario where we would answer this yes and use clinician-guided shared decision-making. And we may find that parents don't have strong preferences after exploring those thoroughly with parents one way or the other. And we could be tempted then to just use strong clinician-guided shared decision-making here and just get explicit agreement that we're going to do this, nutritional option. But here's where calibration might be helpful. We may decide, given the decisional features involved in this decision, it's going to be a parent-implemented decision. They're going to bear the brunt of doing the nutritional intervention with this child. And it's a longitudinal decision. You can't be a one-and-done thing. It has to be over a long period of time. You're going to want to re-enter into some sort of negotiation, like revisit step 3 even, and say, are you sure you don't have strong preferences here, given the fact that this really is going to be something that really you're going to be implementing. It's going to take a while to do. So I would encourage a little bit more interaction, negotiation here, given the longitudinal nature and parent implementation, and therefore a more weak version of clinician-guided shared decision-making rather than a strong version. So let me end, and it looks like we have about 10 minutes left. I'd love to leave time for some questions with one additional slide on next steps. As I mentioned, this is a provisional framework and really done from the clinician's perspective. And there's intent on our end to really continue to flesh this out and add elements to this. And so we've recently received funding from the Agency for Healthcare Research and Quality to do a 3-phase single-site qualitative study to begin some of this additional work and validation work. And what we're going to start by doing is videotaping problem-oriented medical encounters across a variety of pediatric disciplines, both in acuity and settings. So we're going to videotape inpatient encounters, like family-centered care conferences, and outpatient encounters in different disciplines, not just general pediatrics, but pediatric specialties. Really to understand how this framework is manifest. Is it really as applicable as I think it is to a broad array of different settings and different disciplines? And after we videotape these encounters, we're going to meet with the folks involved in those encounters, both parents and clinicians separately. And when adolescents are involved, meet with them separately to talk through how they felt this decision, whatever decision was made at those encounters, how it was made. And we're going to play back parts of that encounter during that interview to sort of stimulate the recall of how things evolved. To really get them to tell us, what were you thinking here, and how shared did you think the doctor was being, if we're talking to a clinician or adolescent, etc. Okay, so this is our attempt also to include the perspective of parents and adolescents here. I think this is an important gap yet in the framework that we hope to close with this study, or at least begin to close. So that'll help us revise the framework, and then we'll conduct separate focus groups of a separate sample of clinicians, adolescents, and parents to assess this revised framework's usability, understandability, and completeness. All of this is really meant to get to a place where we can have an accurate way to capture shared decision making. So we intend to develop a tool after we validate this framework that is aligned with this framework, so that we can begin to measure when shared decision making happens in the pediatric encounter and measure outcomes when it does occur. So let me end there and say that this framework that I've gone through for how and when to use shared decision making in pediatrics is really meant to still be a starting place, but hopefully a helpful starting place for us pediatric clinicians to build upon, add to further, including getting parent perspectives as well as adolescent perspectives. Thank you very much. Happy to take questions.